This presentation is on scapular dyskinesis. We are going to cover the introduction, causes, mechanism, assessment, differential diagnosis, and treatment for scapular dyskinesis. To begin with, the highly scientific definition says that scapular dyskinesis is observed or measured alterations or disruptions of resting scapular position or dynamic scapular sequenced motion. In simple words, the position might be abnormal and or the scapular motion might be abnormal. But to find out what's abnormal, we should know what's normal. So here it is, scapular positioning and orientation. It spans the vertebral level T2 to T7. The normal positions are internally rotated 30 to 45 degrees, anteriorly tipped 10 degrees to 15 degrees, upward rotated 5 degrees to 10 degrees. These values have been taken from the book Joint Structures and Functions by Cynthia Norkin. Then comes scapular motion. On the left side, you'll see the motions produced by scapula. On the right side are the motions available for scapula as a part of the larger shoulder complex. So there's scapular elevation, protraction, retraction, depression. Other than that, it can have upward rotation, downward rotation, anterior tilting, posterior tilting, internal rotation, and external rotation. And the normal ranges are displayed. The position and the motion of the scapula is largely governed by the muscles, and there are a lot of muscles originating and inserting into the scapula. That is why in the images that we find on Google about muscles of scapula, there is this popular picture, the scapular tug of war, because a lot of muscles are pulling it in a lot of different directions. The red ones are the origin of the muscle and the blue ones are the insertion points. Let's have a look at them. Muscles that originate from scapula are deltoid supraspinatus, infraspinatus, triceps brachii, teres minor, teres major, latissimus dorsi, coracobrachialis, biceps brachii, subscapularis, omohyoid muscles. These are the muscles of the neck. Muscles that insert on the scapula are trapezius, levator scapulae, rhomboid major and minor, serratus anterior, pectoralis minor muscles. These are the rotator cuff muscles, supraspinatus, infraspinatus, teres minor and subscapularis with their origin, insertion, action and nerve supply. Here are some more muscles with their specifics given in the table. So now you can see that scapula is like a plate full of muscles. The scapula and the humerus have a lot of muscles in common. And so we have something called scapulohumeral rhythm. You know, during the first 30 degrees of shoulder elevation, most of the movement occurs at the glenohumeral joint and the scapula shows minimal or inconsistent movement. And this is called the setting phase. Beyond the 30 degrees of shoulder elevation, both the glenohumeral joint and the scapulothoracic joint move together in a coordinated fashion, and that's what we call the scapulohumeral rhythm. The ratio 2 is to 1 is significant here. For every 3 degrees of shoulder elevation, approximately 2 degrees occur at glenohumeral joint and 1 degree at scapulothoracic joint. So if the position is abnormal or the motion is abnormal or if the scapulohumeral rhythm is disturbed, then it's definitely scapular dyskinesis. Now we'll look at the causes, which can be shoulder, neck or posture related. Shoulder related causes can be rotator cuff injuries, labral tears, acromioclavicular instability, clavicle fractures, muscle imbalances around the shoulder. Neck related could be degeneration of the cervical spine, nerve root compression at the level of C5, C6, again muscle imbalances related to the neck. Posture related could be thoracic kyphosis, cervical lordosis, slouched posture. There are athletes that can present with this one, and those are primarily the ones who use arm over their head. For example, volleyball, handball, swimming, tennis, javelin throwers are at higher risk of injuring one of the structures of the shoulder. The other high risk groups are individuals who use personal computer. This graph has been taken from a research article, and you'll find the links in the description box. So, this graph talks about the incidence of shoulder injuries in college athletes. It's about 60% of incidence in overhead athletes and about 40% of incidence in non overhead athletes. So, why athletes are at a high risk? This is the mechanism in sports. The repetitive, high load and impact forces experienced in overhead sports leads to fatigue and imbalance in the scapular stabilizing muscles, increasing the risk of scapular dyskinesis. Here are two questions for you. Do write the answers in the comment section. There are terms related to scapula that might be confusing with scapular dyskinesis. So we'll look at that. The first one is scapular winging. It is the term which has been used synonymously with dyskinesis. However, winging is best reserved for altered scapular motion driven by neurological compromise. So, when there is the medial winging that we see most commonly, it's due to the weakness of serratus anterior due to the nerve affected, that is long thoracic nerve. When there's lateral winging, it is due to the weakness of trapezius muscle, which is affected by the spinal accessory nerve. Okay, next one is scapular snapping. Audible or palpable snapping, grinding, or popping of the scapula during movement due to bursal inflammation, scapulothoracic bursitis, bony abnormalities, or soft tissue impingement. What are the symptoms that clients or patients with scapular dyskinesis present with? So it's obviously shoulder pain, weakness or fatigue during or after activity, early scapular elevation or shrugging during arm elevation, decreased efficiency of shoulder function leading to reduced performance, altered throwing or serving mechanics if they are athletes, observable border prominences, and rapid downward rotation of scapula when lowering the arm. There is a mnemonic for it, SICK, sick. S for scapular malposition, I for inferior medial border prominence, C for coracoid pain, K for kinesis abnormalities. How do therapists assess that? We have to observe the position, observe the motion, and check the muscle strength. So, we have already talked about the position and the motion. If you find there is any abnormalities, you can consider that they have scapular dyskinesis. There are also some special tests that can be done. First up is scapular dyskinesis test. So male clients have to remove shirts, female clients have to wear halter tops to clear view of shoulder blades or scapula. The client stands upright holding dumbbells, 1.4 kg if less than 68.1 kg body weight or 2.3 kg if greater than 68.1 kg. The client performs bilateral shoulder flexion and abduction with straight elbows. Movements are done in controlled manner using a metronome set at 60 beats per minute. The examiner stands behind the client and observes scapular movement. The test is recorded as yes or no for scapular dyskinesis. Yes indicates abnormal movement such as asymmetry, dysarrhythmia, or scapular winging. No indicates smooth, symmetrical scapular motion with no winging during arm elevation and lowering. Scapular assistance test checks whether abnormal scapular movement is causing shoulder pain or movement problems. This is because normal shoulder movement depends on proper scapular motion. So the patient can be seated or standing, and the clinician stands behind the patient. First, the patient lifts the arm actively to a point where pain or difficulty occurs. Then clinician manually assists the scapula by guiding upward rotation, posterior tilt and external rotation. The patient repeats the same arm movement while the clinician provides this scapular support. Positive means the pain decreases or movement improves with assistance, indicating scapular dyskinesis is contributing to shoulder symptoms. Negative means no improvement with assistance. This suggests that the problem may be from other shoulder structures. Here is a picture of scapular assistance test. So basically, the scapula is assisted and it is checked whether it improves shoulder symptoms. Next is scapular reposition test, which is used to assess whether poor scapular positioning contributes to shoulder pain or weakness. The patient can be seated or standing, and the clinician stands behind the patient. First, the patient performs a painful or weak shoulder movement, usually arm elevation or assisted external rotation without assistance. Then the clinician manually repositions the scapula by stabilizing it in retraction and posterior tilt. The patient repeats the same movement while the scapula is held in the corrected position. So, positive test means pain reduces or muscle strength improves with scapular repositioning, indicating scapular involvement. Negative means no change in pain or strength, suggesting the symptoms are not mainly due to scapular positioning. Here is a picture of scapular reposition test. We'll follow that up with treatment algorithm, but first comes the disclaimer. The following content is not medical advice, used only for educational purpose. Consult with a medical practitioner first. This has been taken from the disorders of scapula and their role in shoulder injury. We need to look if scapular dyskinesis is present. If it isn't, we continue with shoulder examination because scapular dysfunction is unlikely. So, if we have scapular dyskinesis, we further go into checking if these symptoms can be corrected manually, like through scapular assistance test or scapular reposition test. If that's true, then we look for the tissue source of dysfunction to guide appropriate intervention. Now, there could be soft tissue tightness, and we'll test specific structures that could be axioscapular muscles or glenohumeral capsule and muscles. The other possibility is poor muscle performance. If it is readily correctable with cueing and conscious effort, then we consider it a motor control deficit and determine corrective strategies. If not, then there might be true muscle weakness due to neural injury or disuse atrophy. Now that we have identified the tissue source of scapular dysfunction, we can put the patient on Dr. Ann Kuhl's scapular rehabilitation algorithm. With lack of tissue flexibility, we can go for stretching and mobilization, manual soft tissue techniques, manual stretching, home stretching, mobilization with movement of the affected muscles. With lack of muscle performance, we can go for muscle control and muscle strengthening. That can involve neuromuscular coordination, conscious muscle control, advanced control during basic activities, and during sports if it's an athlete. For strength training, we can go for conscious muscle control, balance, ratio, and endurance and strength training. Some things might be new here, like the conscious muscle control, balance ratio, and we'll look at that now. So, stage 1, conscious muscle control and flexibility, goes for week 1 to 2. The goal is to normalize scapular resting position and improve flexibility. The key interventions involve posture correction, flexibility and stretches, isometric scapular retractions, gentle ROM, and pain management as needed. Stage 2, we have muscle activation and strengthening, that's week 3 to 6. The goal is to activate and strengthen scapular stabilizers, improve co-contraction and movement patterns. The key interventions are close kinetic chain exercises like wall push-ups, scapular clocks, rhythmic ball stabilization, isometric extension. Progress to table push-ups, modified prone push-ups, and so on. Next, we have open kinetic chain exercises, low row, lawnmower, robbery, and inferior glide exercises. which are also called Kibler protocol. So sideline external rotation, prone extension, sideline forward flexion, prone horizontal abduction with external rotation can be done. There is also selective activation. So focus on lower trapezius, middle trapezius, serratus anterior with minimal upper trapezius activity. Next, we have scapular control with arm movement. Start with arm close to body, progress to higher elevation as control improves. Advanced strengthening and functional integration, that's from week 6 to week 12 and further. The goal is to achieve active scapular control, integrate kinetic chain, and prepare for sport specific demands. So the key interventions are dynamic strengthening, push-ups plus, prone Ys, Ts, Ws, especially on unstable surfaces if tolerated. Proprioceptive neuromuscular training, kinetic chain integration, add trunk hip movement like lunges with dumbbell reach, land mower with lateral step, robbery with posterior step. Incorporate lower limb core activation to enhance scapular muscle recruitment. Then we have sport specific drills for athletes. Overhead athletes go for plyometrics, eccentric loading, functional diagonals with resistance, pants and balls. Swimmers can have prone, supine core stability exercises. Gymnasts and climbers high level closed chain exercises. When are athletes ready to go for play? So this is return to play criteria. First of all, no pain. Second, near normal range of motion and strength, symmetrical scapular movement or 10% dominant side advantage in overhead athletes. Pectoralis minor index less than 8.61, less than 20% internal rotation side difference, less than 10% total ROM difference. So the athlete has to achieve all of this as given in the criteria to be ready to participate in any competitive tournaments. What are other things to keep in mind? Educate on the risk of fatigue, monitor training loads and techniques, ensure proper warm up and cool down routines. Scapular muscle strengthening and endurance have to be maintained, and there should be proper sequencing, like emphasize the role of legs and trunk in generating force and reducing shoulder load during throwing or serving. What I mean by this is, I'll give you an example. So if you have been to gym or have been into powerlifting or weightlifting, a beginner will usually use their shoulder muscles to lift that weight, and they won't remember that it's the quadriceps and the core muscles that are involved in lifting the weight. So, in powerlifting or weightlifting, the force is generated by the lower body so that the weight can be lifted by the upper body, and that's something that beginners take time to understand. Another question taken from a research article: all three of these individuals are elite boxers and they present with some kind of shoulder dysfunction. So, do all three of them have scapular dyskinesis? Do post it on the comment section. A thing to keep in mind is there can be varieties of scapular dyskinesis because different muscles can be affected in different individuals. So, the treatment plan will vary for all. So let's have a proper assessment and targeted intervention plan. That's all on scapular dyskinesis. Thank you for watching.